Good morning, one and all. Welcome to Pharma Zone. I'm Dr. Sirisha, and today's topic of discussion is phenytoin, which is an anti epileptic drug. Before going into topic proper, let us have a small idea about what is seizure, what is convulsion, and what is epilepsy. Seizure is primarily an episode of brain dysfunction mainly due to abnormal discharge of cerebral neurons, whereas convulsions is primarily a symptom where a skeletal muscle is being either in prolonged contraction or in spasmodic state and usually involuntary in nature. Then what is epilepsy? Epilepsy is primarily a group of seizures or a syndromes which may have multiple mechanisms and all are characterized by the same feature of sudden excessive discharge from the cerebral neurons. Majority of the times this discharge is either idiopathic or secondary. Coming to the epidemiology, usually the seizures are highly seen in newborns, early school age kids, as well as in adolescents. The incidence again increases in elderly people. And what is the neurophysiology of epilepsy? Usually, either there is too much of excitation or too little of inhibition. The excitatory neurotransmitters include glutamate, and the receptors on which they act are NMDA receptors, whereas the inhibitory neurotransmitters are GABA, and the receptors on which it acts is also termed as GABA. Coming to the basic pathology, usually in generalized seizures, there will be asynchronous opening of sodium as well as calcium channels, because of which, in generalized seizures, drugs which mainly act on sodium channels and calcium channel blockers are usually used. And the primary pathology in generalized seizures usually lies in thalamus. For that reason, we specifically target T type of calcium channels. The best example for these drugs which can be used in generalized seizures include phenytoin, valproate, and carbamazepine. In absent seizures, the major issue lies with the calcium channels of thalamus. For that reason, the drugs of choice usually are calcium channel blockers, and though there are a lot of drugs like ethosuximide, these days we use only valproate. Coming to the focal seizures, the primary pathology lies in the asynchronous opening of sodium channels, and the drugs which can be used effectively include sodium channel blockers, primarily carbamazepine. Let us do know what is a partial seizure, primary generalized seizure, and an unclassified seizure. Usually, partial seizure involves a small area of brain and are further classified into simple partial, complex partial, or partial seizure with secondary generalized seizures. Whereas the primary generalized seizures are classified into absent seizures, generalized tonic clonic seizures, atonic seizures, tonic seizures, and myoclonic seizures. Here, usually global involvement of CNS is seen. Unclassified seizures include neonatal seizures and infantile spasms. And one major and life threatening seizure episode is status epilepticus. What usually happens in focal seizures? Focal seizures is a scenario where a small part of brain is involved, and usually this may be sometimes generalized to wide areas, resulting in focal seizures with secondary generalization. The same logic applies for generalized seizures, where the primary focus of the seizure will be from thalamus, from where the asynchronous firing of neurons will be widespread. Anti-epileptic drugs are classified into barbiturates, deoxybarbiturates like primidone, hydantoin like phenytoin and fosphenytoin, immunostilbenes like carbamazepine, oxcarbamazepine, and eslicarbazepine, Succinimides like ethosuximide, aliphatic carboxylic acid like valproate sodium and divalproex, benzodiazepines like clonazepam, diazepam, lorazepam, clobazam, phenyltriazines like lamotrigine, cyclic GABA analogs like gabapentin and pregabalin, newer drugs like topiramate, levetiracetam, zonisamide, vigabatrin, tiagabine, and lacosamide. Today, we are going to talk about phenytoin. But before knowing that, let us also classify our anti-epileptic drugs based on mechanism of action. Drugs which primarily act on the sodium channels by prolonging the inactive phase. Best example for that is phenytoin, carbamazepine and valproate. And the second group which include inhibition of excitatory glutamate response. The same way, phenytoin and valproate can be grouped under these. Coming to the third mechanism of action, where there is increase in the action of facilitation of GABA mediated chloride channels. Best examples are barbiturates and benzodiazepines. Inhibition of T type of calcium channels. T type stands for thalamic type, which is primarily present in CNS. Best example includes ethosuximide and valproate. This is basically a pencil diagram of the same mechanism, of the same channels per se, where there is either prolonged sodium channel inactivation or facilitation of GABA or inhibition of T type calcium. Prolongation of sodium channel inactivation, best example is phenytoin. GABA facilitation, best example is your benzodiazepines and barbiturates. Calcium channel inhibitors, primarily, best example is your valproate and ethosuximide. The same in a flow chart where sodium channel blockers, calcium channel blockers, potassium channel blockers is a newer addition. Best example for them is ezogabine, glutamate blockers, which can be glutamate receptors include NMDA blocker like felbamate or AMPA blocker like talampanel. Drugs acting via GABA, which may include many drugs, but of all those, GABA releaser is pregabalin gabapentin, GABA transaminase inhibitor is vigabatrin, GABA reuptake inhibitor is tiagabine, GABA agonist is benzodiazepines and barbiturates. SV2A inhibitors, levetiracetam. Today's topic of discussion is only phenytoin, which belongs to hydantoin group. It is the oldest non-sedative anti-epileptic drug. Primarily, it stabilizes the neuronal membrane by preventing repetitive detonation of normal brain cells. Phenytoin prolongs inactivated state of voltage-sensitive neuronal sodium channels. Here, before going any further, I want you to know the structure of sodium channel. Sodium channel has an activation gate or a make gate or M gate which is extracellular, and then a transmembrane ion channels, and then an inactivation gate, halt gate or H gate. When the activation gate as well as the inactivation gate is open, then only the sodium ions move through and through. Because of this mechanism, there are three stages of sodium channels where the sodium channels can be either resting state, or they can be in the active phase, or they can be in the inactive phase. Where in the resting phase, both the H gate and the M gate are closed. Whereas in active phase, both are open so that the drug can move through and through. Whereas in an inactive phase, the M gate is open, that is, the extracellular gate is open, whereas the intracellular halt gate is closed. This phase is called as inactive phase of sodium channels, and phenytoin primarily increases the duration sodium channel stays in inactive phase, because of which there will be reduced membranal stability will be attained and reduced asynchronous firing will be seen. The same in a flowchart where phenytoin primarily causes delayed recovery of sodium channels from inactivation phase, blocks sodium channels in the inactivated state, because of which there will be stabilization of the neuronal membranes. Because of this neuronal membrane stabilizing property only, it inhibits generation of action potentials and also prevents asynchronous firing, because of which there will be inhibition of spread of seizures. Along with this, it also blocks high frequency firing. Because of all these actions, phenytoin establishes anti-epileptic activity. Phenytoin is slowly absorbed, obviously, but it is completely absorbed and it is never given parenterally, primarily IM because it precipitates in the muscle and causes pain, intravenously because it causes severe thrombophlebitis and can precipitate hypotension. It is highly protein bound and is a potent enzyme inducer. It follows mixed order kinetics. What do I mean by mixed order kinetics is at lower concentrations it follows first order kinetics, whereas on higher concentration it follows zero order kinetics. These days, phenytoin has lost its sheen and is rarely used because lot of side effects. It became a second drug of choice in many epileptic conditions. Though it can be used as drug of choice in treatment of partial seizures, second drug of choice in GTCS and status epilepticus. Non-epileptic uses include trigeminal neuralgia and ventricular arrhythmia due to digitalis toxicity. In these two conditions, the membrane stabilizing property helps us in reducing the symptoms. As I already mentioned, phenytoin lost its sheen due to lot of adverse effects. Then what are these adverse effects? They are primarily grouped into two, where chronic toxicity, which is seen after prolonged use, as well as overdose toxicity when high doses are given. Mainly, overdose toxicity includes nystagmus, ataxia, CNS depression, lethargy, blurred vision, and on intravenous injection when high doses are given, collapse and coma can occur. The major issue with phenytoin is it cannot be given in pregnant females. Fetal Hydantoin syndrome happens in them, which primarily include hypoplastic phalanges, cleft palate, hair lip, microcephaly, and all these toxicity, all these features occur primarily due to arene oxide metabolite of phenytoin. Hypersensitivity reactions like rashes, diffuse lupus erythematosus, lymphadenopathy, and neutropenia can also be seen. The best way to remember fetal Hydantoin syndrome is PCM, where P stands for hypoplastic phalanges, C stands for cleft lip and cleft palate, M stands for microcephaly. Then, what are the other adverse effects? Gingival hyperplasia, which is very prominently seen, and this can be somewhat minimized by maintaining proper oral hygiene. In the same way, due to folate deficiency, it can cause megaloblastic anemia, it can cause vitamin K deficiency, and as well as osteomalacia due to vitamin D deficiency. Along with this, for a female, it can cause hirsutism, acne, worsening of facial features on prolonged use. Acute symptoms primarily include ataxia, vertigo, diplopia, and nystagmus, drowsiness, mental confusion, hallucinations. Never is phenytoin given intravenously, mainly because it causes severe thrombophlebitis and may initiate an anaphylactic response, which is usually presented with fallen BP, that is hypotension. This is how we usually remember adverse effects of phenytoin. P stands for P450 drug interactions, H stands for hirsutism, E stands for gingival hyperplasia or enlarged gums, N stands for nystagmus, Y stands for yellowish discoloration of skin, T stands for teratogenicity, osteomalacia, interference with folate, vitamin B12 as well as vitamin K absorption, and then neuropathic symptoms like vertigo and ataxia. Because of all these, phenytoin lost its sheen. But primarily, when it has to be used in a emergency situation, this phenytoin cannot be used because intravenous route causes severe thrombophlebitis and can cause hypotension. To overcome this, a small change in the chemical structure of phenytoin resulted in the production of water-soluble prodrug called phosphenytoin. This immediately gets converted into phenytoin in the plasma, and this is primarily used in status epilepticus, where emergency administration of phenytoin is mandatory. In this condition, phosphenytoin is given intravenously. I think I am clear with the concept of phenytoin in epilepsy. Thank you for patient listening.